It's just natural. And it's so cool because I think that's such a unique thing to touch on because it impacts our health, our life, our relationships in so many different ways. It's forever ongoing in the amount of ways that it can impact.
Hey, everybody. Thanks for joining the First Optimal podcast. Really excited. We have McCall McPherson here today, and she is a thyroid health expert, amongst other things that we're going to get into and unpack. So a lot of really great stuff. She's also highlighted as a key speaker at many events. There's a menopause show coming up that we're not sure if it's going to be out. It may already happen after this event. So that's in California, October 5th and 6th. So this episode might be released after that. But nonetheless, we're really grateful for her to take the time to come on because she's definitely an expert in her space and creating a lot of really great resources, content, and services to people out there. So thanks for joining us.
Hey, thanks so much for having me. I'm so excited to be here and have the conversation.
Good stuff. Well, we were chatting a little bit before we got the recording going. So you are in the Austin area, right?
I am. We're anxiously awaiting a little fall respite from the heat, hopefully
Yeah.
soon.
Yeah, ours started this week. It's warmed up a little bit here in Michigan, but we're experiencing some slight cooling off, just slight, just enough.
I'm
But
jealous.
yeah, we'll see. So yeah, I thought it would be fun just if they have not come across your content or some of your
Mhm.
information that you're putting out there, services, just kind of walk through a little bit of your journey to get to where you are today. Um,
Yeah.
a lot of really detailed, um, I would say, challenging topics that you unpack and get really into the weeds with your content. That's really why we were very excited to try to get you on. Um, and that takes a lot of time, effort, and passion. So I'm always curious to people where, not to discredit those who are more broad in their approach, like there's some utility there and value, but then those who are just super dialed in and kind of leading those discussions is always exciting for me to understand the why and then also get into the fun nuggets there. So I was wondering if you can unpack some of that for us.
Yeah, I'd love to. So, I am a PA. I'm a physician assistant, or I guess what's called physician associate now, by way of conventional medicine, normal approach. I was 27 when my thyroid absolutely took me down, Hashimoto's, hypothyroidism. I was literally in bed 16 hours every day. So I was practicing medicine, already on thyroid medication, already on brand name thyroid medication, Synthroid, and knew enough, obviously, to be like, oh my gosh, I really need an adjustment on my meds. Go to my doctor and tells me, no, your TSH is fine. Like, this isn't your thyroid, even though you have like 80% of thyroid symptoms, and eat less, exercise more, go on your merry way. So I go back to him after doing some research, reading. I'm like, hey, I found these extra labs. Can you run these on my little post-it? Right. And he came back and said, no, like, I'm not
Mm.
going to. Even with your TSH, we probably need to reduce your medication. And by the way, you have a cholesterol issue, and let's put you on Lipitor at 27. And I was bawled, cried, got on the wait list for one of the only functional medicine, integrative medicine physicians that specialized in thyroid back then. This was a long time ago. Saw him a few months later, and he completely changed my life. I went from literally being bedbound every moment I was not outside of work to thriving. And obviously, that'll motivate you a little bit. It's like,
Yeah.
wow, if I'm struggling like this and everyone is telling me that there's nothing wrong with me, but it completely took over my life, there has to be other people like this. So I learned everything I could on thyroid. He became a mentor to me very, very quickly. And over the years, I ended up passively, honestly, creating Modern Thyroid Clinic out of a movement that my patients took online to every thyroid advocacy platform, spread the word about me and my care. And, Modern Thyroid Clinic has been dedicated to this thing for over 10 years now. And it's been an honor. Like, we've been able to collect immense amounts of data, revise and hone and evolve our treatment, our diagnostic. Like, we have done the data digging and the analysis so repetitiously and intentionally that I truly believe what we offer is unlike anything else. And Now we started as a brick and mortar practice, but we had
Mhm.
people flying in literally from all over the country, all over the world. We ended up with an 8,000 person wait list.
Hmm.
And I'm like, we've got to do something.
Uh-oh.
Like, there's
Yeah.
all these people need help. So now we are a nationwide telemedicine company. And it's my goal in my lifetime to expand access for these people that are repeatedly told, hey, your thyroid is not your problem when it is. And it's so impactful in long term health that I'm just grateful to be on the journey with them, and to have been able to make my mark and continue to in this field.
Yeah, it's no, it's always so interesting, where the story behind what gets people to where they are, and then, you kinda I think it's just such a cool thing to, one, experience, but two, to interact with people that do that. Like, some of the best
Mhm,
practitioners that I've worked with if something I needed help with, um, if they had that story or that journey, or even some things that I do in the coaching realm, I volunteer and help out because when I played sports, um, I had good and bad coaches, and some kept me out of trouble because I didn't grow up in the best of areas, but then others were not so good, and so it's just like to have that, even though, it's a small nugget compared to, what you're doing at the scale you're doing it. It's just such a neat thing, and I think for a lot of people out there too, there's a different level of engagement and appreciation when they're meeting with somebody who's actually been through that, or they're, people on their team have been through it. So
mhm.
I really appreciate you sharing that, and I'm curious to, when you first started to put out information about thyroid and offering your services, like, what were some commonalities? And I know we're painting with a broad brush here, but I'm just curious, like,
Mhm.
commonalities of what you're seeing. Were they similar with men and women? Are there differences in men and women? Just maybe if you can kind of unpack that. I know it's a more high
Yeah.
level overview question, but just curious to what you were experiencing.
Yeah, so, like, 99% of our patients are women.
Mhm.
I think that isn't necessarily reflective of the disparity between men and women with thyroid issues, but I think there is substantially more women that are impacted with any kind of thyroid dysfunction as compared to men. And then I think also most women are just like a little more engaged in how they feel and their
Yeah.
health. And, research shows women are even diagnosed with cancer 5 years later than men because they're not taken seriously. And so I think that also trickles down to, hey, women need a safe place to go
Mhm.
where they know that someone will believe them. So generally it's women. I would say the majority of our patients are like, 30s, 40s, 50s, but they go all the way from much younger, much older, certainly. Most with actually all with some form of what I call a conversion disorder. So difficulty converting their inactive hormone, their T4, to their active hormone, their T3.
Mhm.
And that's ubiquitous in our patients. And I think that translates to a very high percentage of the population that is completely left out in the cold and not helped with the current way we are treating pretty much every thyroid patient in our medical system.
Yeah, and it's when you're seeing them come in, is there differences between, say, um, prior to midlife perimenopause kicking in to a woman, maybe it's early 30s, or what have you, to perimenopause women, to menopause women, as it relates to their thyroid health? Is there any, differences there in those different stages, or they're similar? How does that work?
I think they present very similarly. I think once women get to like perimenopause, menopause, they get really confused. Like,
Mhm.
and thank God now we're even talking about perimenopause because for the last, forever, no one ever did. It was just black and white, pre and menopause. But I think people don't know what's hormones, what's thyroid. Like, what if this is all just hormone? They don't
Right.
even think about thyroid because our medical system doesn't really think about thyroid. So the water gets really muddy there. And obviously, we have to dive headfirst into thyroid and hormones simultaneously because a lot of times both of those are driving symptoms, whereas younger people are more thyroid directly, Hashimoto's directly. But it's interesting, studies also show incidence of hypothyroidism and Hashimoto's increase after menopause.
Mhm.
And so there's obviously a huge resurgence there as far as it happening. But again, I think women don't know. They're confused between thyroid and hormones, unfortunately.
No, it makes a lot of sense. I mean, it's because when you're looking at the thyroid, I'm curious to get your take as coming from, I guess the best way to describe it is like more traditional medical or like the sick care, if you will, model. Why is it, do you think that it's kind of the TSH and go approach where
Yeah.
it's just that quick snapshot and most of the time it's not really being dug a little deeper in that space.
Yeah. That is such a problem. Like, I was just looking at some statistics the other day based on like 89 national lab facilities, and pretty much 70% of the time, TSH is the only thing that's checked for workup of, a thyroid issue. And then, hey, the follow up thing, really, it should be done the first time, a full panel. But if anything, they'll check a free T4, which is useful, but not enough. Only 14 out of every 100 clinicians check, or 14 patients out of every 100 get their T4 checked, and 4 out of every 100 get their free T3 checked, their most important hormone. So it's interesting. I think, medicine, I feel, has abandoned the evolution of thyroid. I mean, I think that it's just people are not invested in it. And in fact, we're devolving in the world of thyroid care instead of everything else is evolving, right? And I feel like we're kind of, again, we're left out in the cold. I also think insurance drives a lot of this conversation. I know that if clinicians who are in the insurance model want to check a full thyroid panel, get the real picture that people need to
Yeah.
know to see what's going on, if they keep doing that, insurance companies come to them and they say, "Hey, you're costing us too much money. If you
Mm.
keep doing this, we're going to drop you from our policy." And so we've just been stagnant now for decades.
Yeah, and it's you're seeing it. Gosh, I do want to get into markers more, but my
Yeah.
brain's jumping around because are you? I'm sure you're familiar, but some of the recent FDA information coming out around Armor Thyroid. For those out there, it's actually one of our top like trending articles that we put out. I'm wondering if you could unpack what it is I'm
Yeah.
talking about, and you're definitely much more the expert than I to describe it, and then what's going on there.
Yeah. This is such a good question. And I should have talked with you about this before we even started. I'm so grateful you brought it up. So there is a class of thyroid medication called natural desiccated thyroid. It's actually pig thyroid gland, and they make it into a medication. It was the first type of thyroid medication available in the country, and it was around for a half of a century before
Mhm.
levothyroxine was developed. There are several brands of these medications already on the market: NP thyroid, Armor thyroid, Ren thyroid, Nature thyroid used to be available, WP, etc. Most of the available desiccated thyroid medications now, for the first time in history, have begun the approval process with the FDA. These medications have never been FDA approved because they existed before the approval process began. And
Mm.
so they were grandfathered in, right? So for the first time in 100 years, over 100 years, these meds are going for FDA approval and already are in the process. And all of the sudden, in August, the FDA came out and said, sent us letters as clinicians prescribing these meds, sent manufacturers letters who make the meds and said, all of this has to stop in 1 year.
Mm.
We are removing these drugs from the market until they're FDA approved, which none of the companies that are in the process of FDA approval will be approved by then. It's going to take 2, 3, 4, 5 years before that happens because
Yeah.
it takes time. So, to remove access to these meds for millions of people, somewhere between about 2 and 4 million people, these are the meds that gave me back my life for sure. These are meds that I prescribe all day, every day. It would be a travesty. So, myself and pretty much most every leader in the industry came together and we formed what's called the Thyroid Health Alliance. We'd love for you to join. You, Joe, your team, but anyone listening too, go to thyroidhealthalliance.org, and there's a few steps to take to get involved. We are working closely with so many people to continue to evolve this process. At one point, the FDA came out with a tweet that said, "Oh, don't worry, everyone. We'll keep these drugs on the market until there's FDA approved options." Well, honestly, no one has been told that they're allowed to continue production, prescribing. Nothing has ever been formalized outside of that tweet. So we have to band together and continue carrying on this message because it's a really big deal.
Yeah, and for those listening on audio, we will have it in the show notes. But here's the I was just pulling up the site here, and it, of course, as soon as I pull it up, it popped your face off there.
Yeah, that's fine.
So it'll run its course. But yeah, Thyroid Health Alliance. So this is where people can go to um, register and kind of give to help support the cause of kind of keeping those things online. Would you say?
Yeah, I think the most important aspect of creating a movement and impact is uniting together. Like this is everyone in this space that has is dedicated to it, and we want to unify our voices even between competition. Like Paloma Health is one of my competitors.
Mhm.
Literally, I talked to them to bring them into this movement because we need one united voice, one united mission. And our ask is simply that the FDA wait until at least two companies receive FDA approval to remove access from the ones that are not FDA approved.
Yeah. Do you have any inclination or insights on why the change, or why did the FDA start some of this? Has there been anything shared in your
Yeah.
circles or?
Yeah, I think it's a couple things. One, one of the companies going for FDA approval created a citizens petition for the FDA and asked everyone else to be removed from the market. And that really made the FDA angry, I think. And
Mm,
they wrote, they responded in a pretty negative way to that. Second, I think, these medications used to be wildly unstable. They did. For the
mhm,
first 60 years, they did not really have it together. It was hard to control hormone levels, et cetera. Since about 1984, that has vastly improved. And for the most part, these drugs are pretty stable. But there are certain companies, certain brands that don't have the stability that others do. And there is a lot of dosing volatility. So I
mhm.
think that's problematic. And it fuels this idea that these drugs are not safe, they're not stable, they're not predictable. I also think prescribers were not trained how to use these meds. We're trained to be afraid of them. We're not collecting lab data correctly to facilitate an understanding of how they work because nothing is standardized. And so, again, we are allowing this myth to be propagated when a lot of them are. Some of them have a 7% variance, like up and down. That's a quarter as much as generic versus, brand medication. So this is a fixable thing, and we need to protect access to these drugs. We cannot lose access to them.
Yeah, and it's just for those out there that maybe aren't as familiar, like what would you say are the differences in these medications and the abilities versus say the synthetic versions? Like
Yeah.
what are some reasons why this is cause for concern?
Yeah, good question. So, these drugs are a blend of T4, which is what levothyroxine is made of, but it's synthetic, and T3, which is active thyroid hormone, what we need to feel good, thrive, hair, skin, digestion, libido, all of it is T3 dependent. It also has some cofactors in it because it is a full and complete thyroid gland from a pig. It has other cofactors, minerals, T2, T1, things that are not replicatable in a synthetic form. I think an additional concern for me is, when I get a letter that says in 1 year, you need to have all your patients transitioned off of these meds, it takes several treatment cycles to successfully transition someone from a very short acting type of medication like Armor to levothyroxine and Cytomel. That is a complex biochemical change that is delicate and can easily make people not feel well in the process if you don't have plenty of time to facilitate it. And it's not as simple as, hey, we're just going to change you from levothyroxine to Synthroid overnight. Like, no, this is a very, very complex thing. And Most people on desiccated thyroid have failed treatment with synthetics, either in the T4 category or combination. And they're not for everyone, they're not everyone's answer, but they're the answer that worked for millions of people when nothing else did.
Yeah, and I'm not as familiar with quite all the nuances within a synthetic application, but I'm curious if I read something somewhere. I may be wrong on this, but the timing or the way they metabolize, is there some
Yes.
differences there? Because I've seen some people that had some pretty aggressive negative side effects from how the synthetic was being metabolized and kind of the timing of it being converted or released versus
Mhm.
like desiccated.
Yeah.
Is there some truth to that, and how does that work?
Yeah. So, I mean, desiccated has both active and inactive, but like if we start with the inactive in a desiccated thyroid kind of waxes and wanes on a daily basis. Like it's pretty short acting. Whereas if you're on levothyroxine or Synthroid and you stop it today, half of it is still in your system in 7 to 10 days. That is an extremely long half life. So imagine just with those hormones, shifting people between medications is quite complicated. T3 in Armor or Thyroid or NP peaks and troughs in about 6 to 8 hours in our bloodstream. So it is short acting, but it's reasonably smooth. Something like Cytomel or liothyronine, which is pure T3, pure active hormone, the synthetic equivalent we'd have to do to replace the T3 in desiccated thyroid, peaks and troughs in like 3 to 6 hours. It's a lot more volatile, and so people feel overstimulated, they feel jittery. And then just think about the transition. When someone comes into me on a lot of levothyroxine, oh, I'm on 150 micrograms of levo. Will you switch me to Armor, let's say? Well, think about the half lives. What normally happens with those people is they stop levothyroxine on a Monday, they start the quote equivalent dose of Armor that Monday. So they've effectively doubled their dose
Right.
overnight. Right. So again, it's like these transitions are very complex. Most people don't know how to effectively do them. And trying to get everyone in the country to do that in a really short period of time is a very poor plan. And it's definitely a way where people are going to have bad things happen. It's not safe even to double someone's thyroid medication overnight.
Yeah, no, that makes a lot of sense. And I think there's a lot of, practitioners out there that maybe, aren't as nuanced in the differences, details, or pharmacokinetics of, these treatments or therapies that not at any fault of their own, because they're just following the marching
Right.
orders, from above. But it's just, to understand those things is, I'm sure many, many more will ring that bell to say, oh, this isn't the best of ideas, not the best plan here, once they understand how that works. Because I find that often there's some really brilliant physicians out there, but there's so many details and so many new
Mhm.
delivery mechanisms and ways to things can be metabolized in the body, et cetera, that they just can't keep up on all that. Not every, unless it's like someone like yourself who's just completely dialed in on thyroid
One
health and
thing, right?
staying on
Like
it.
a few,
Exactly.
exactly.
And that's where it's, sometimes it can be a bit of a struggle if someone's, you never want to, I try to, we try to talk to people a lot, or in even discussions, if I'm just even just talking to a friend, is context matters. Like, okay, yes, if I'm in a car accident or have some severe illness, this our medical system is set up brilliantly for that. If you're looking for
Mhm.
optimization and to feel better and be peak, it's not set up for that way. So it's not that they're bad or they're not wanting to help you, or whatever the case may be. It's just the way the whole system is made is just completely different. So
It is. And, our medical system is made to help us when we're sick, injured,
right,
hurt. It is not made to create health and wellness
right,
and people to thrive. Those are two very different things. And I'm hopeful people are beginning to realize that, I think. Whereas years ago, 5 years ago, even, that was not the case. And that creates, a little more opportunity for healing.
sure. I had one more selfish question, and then I promise we'll zoom back out for the audience too, because I wanted to hit some other areas around thyroid health. But medication specific, this is, oh gosh, it might have been 4 or 5 years ago, and so I don't know a lot about it, admittedly, but I do recall hearing about a T3 version that was like an extended release.
Mhm.
Is that is that true? Is that something that's out there? And what forms are those in? Is it both forms, or is it just one? Just curious
Good
to that.
question. Yeah. So apparently that is still in development. It is not
Okay.
active and live to be released yet. I was so excited about that, honestly. Like I tracked
Yeah.
down the manufacturer and I'm like, if I can help with this in any way, please let
Sure.
me know because we need it so badly. The only available sustained release form of T3 right now is compounded. And while I love compounded medications, I will not compound thyroid meds because we are dealing with micrograms. Like when we take, 100 milligrams of bioidentical progesterone for hormone replacement, that's milligrams. Okay.
Right.
That's like baking muffins and putting an even amount of chocolate chips in every muffin in the dozen. Kind of easy, like doable,
Sure.
pretty able to get close. When we're dealing with micrograms, we're dealing with poppy seeds. Like we are trying to get the
Mm,
same dose of poppy seed in every batch and supply and pill, and that doesn't happen. So I stopped prescribing compounds in 2018 when I hit the threshold. I'm like, I cannot do this anymore. I had a totally stable patient. She came back, her TSH was 12 because 3 months, the 90-day supply of compounded meds is what people get. That's enough time to completely derail someone's thyroid hormones if it's not compounded correctly. And the likelihood of that happening is not a matter of if, but when.
that makes a lot of sense. Yeah, because it was a compounded source that I saw it, and then I was talking to a friend of mine who's actually my general practitioner, and was just curious because we were talking a little bit before we started recording about just different family members that are the ones that are the less than 1% side effect prone. And so actually one particular family member clearly needed, even worked with an endocrinologist on, you know, hypothyroidism, and didn't quite have the markers to say like clinically there were, but definitely had all the symptoms. My point is they were struggling with finding that sweet spot with their T3. And so the thought was, oh, if there's a extended release, they never ended up going down that path, but would that lessen the likelihood of these anxious, hyperactive, jittery feeling, and just kind of smoothen a little bit. And so
Yeah.
I've seen some dosing protocols by some practitioners that one would look at and say like that's not going to do anything, it's so low. But it's like some people are so sensitive, I would imagine you have to
T3
start at
is
a certain
potent.
place and slowly move it up.
Mhm.
So
Yeah. T3 is powerful. Like it
yeah.
really is. It can easily overwhelm your system. And there are ways to work around that, obviously by going slow, but reducing TSH is another powerful way to mitigate those symptoms because the higher someone's TSH is, the more prone to those feelings they
Mm.
are. And yeah, there are little tips and nuances, but yeah, too much T3 is not comfortable.
No, it makes sense. And with that, I'm wondering just to kind of zoom back out for a moment. Let's say someone's listening to this and they're like, "Well, I think that's me." Like, could you maybe give a high level of this? Maybe symptoms related to underactive, overactive, etc. Any of the common therapies or things you're diagnosing in your practice?
Yeah. So let's talk first about like hypothyroidism because that's the vast majority of people.
Sure.
90+% of thyroid people have hypothyroidism. And those are symptoms like that I have: fatigue, brain fog, weight gain, hair loss, hair breaking, short nails, loss even of the outer portions of your eyebrows, constipation, low sex drive, kind of brain fog or flat mood, almost depression.
Mhm.
Most people will end up being told, hey, your blood sugar's elevated. You have high cholesterol, just like me at 27, right? Like they have these secondary issues that start showing up that generally, sadly, people are more willing to treat than their actual thyroid condition. Um, in addition to that, a lot of those people have Hashimoto's, which is an autoimmune condition that attacks your thyroid gland and it erodes away that tissue that secretes hormones and it replaces it with like the scarry inflammatory tissue that just can't efficiently work anymore, right?
Mhm.
So those people end up with hypothyroidism. And there's a couple key differentiators for people with Hashi. You always want to check labs, but they sometimes have more anxiety. Like I tend to notice there's a correlation with increased anxiety and Hashi. They'll even think they have hyperthyroidism, but in fact, they just have Hashimoto's. And often they'll have like a swollen thyroid, like a goiter, which
Mm.
I had so severely too. The flip side of that conversation is hyperthyroidism, and that's like an overactive thyroid. Commonly, initially, before people are medicated for this, it leads to anxiety, palpitations, shaky, jittery, have difficulty sleeping. They too can lose hair. They also feel like wired but tired. One of the
Mhm.
first things these people notice is like, I go to the gym and I don't do anything barely, and my heart rate's like 180. Like they
Mm.
can't tolerate exercise, they have heat intolerance. And that can be from Graves' disease, which is the autoimmune component that propagates hyperthyroidism, the attack that creates that, or it can be nodules and things that secrete too much thyroid hormone. And these people have a particularly rough go at it. It's having Graves and hyper is tough because medicine's treatment still is very subpar. There are better ways of doing it, and that's certainly what we do at Modern Thyroid Clinic, but it's tough for those people.
Yeah, and when you brought up nodules, it reminded me of a few follow-up questions that, not being a clinician myself, I know enough to be dangerous on the topic, so I won't try to describe it. I think I'll defer to you on this, but I'll do my best to tee up my question. So, you have these GLP-1 therapies, right, for weight loss.
Mhm.
There's a concern, and I would like to ask where this concern came from because I think I know, but I'll ask you
Mhm.
first. Related to like past history of a thyroid cancer, and then I'm also curious too, are there any contraindications if they have nodules but they're not, cancerous? Like, I wonder if you can kind of walk through that, and I'm sure I may have a few follow-up questions to that, but I'm just curious to your expertise on that.
For sure. So I'm particularly invested in this conversation because I'm obviously the founder of a nationwide practice for thyroid, Modern Thyroid Clinic, but I'm also the founder of our sister company, Modern Weight Loss. And before we formed Modern Weight Loss, which is a GLP nationwide weight loss company, we started that program within Modern Thyroid Clinic, treating people with thyroid issues that could not lose weight with effort, no matter what they did.
Mhm.
And it was like the last piece of the puzzle for us. And so I wanted to be very sure that we were not going to cause our thyroid patients issues. So let's back up to why there is a black box warning on GLP 1s for a thyroid cancer called medullary thyroid carcinoma.
Mhm.
And it happened because in rats, when we initiated these studies, we found an increased incidence of a particular kind of thyroid cancer, medullary thyroid carcinoma, which accounts for about 3% of all thyroid cancers. It's very rare. There was an increase in this. And when you look closer, a couple facets kind of unravel. Number one, these rats were put on 20 to 100 times the equivalent dose that humans get. So,
Mhm.
probably a problem, right? Number two, um, they have incredibly dense GLP receptors, particularly on their thyroid, that humans do not have. And so, because of what was manifesting in rats, the FDA put the black box warning for humans, but there have been so many studies following this up. One, I think the biggest one, the most trusted one for me was a international, multi-continental study and a meta-analysis looking and comparing people on GLPs and thyroid cancer, and obviously on other forms of diabetic medications. No statistically significant risk whatsoever
Mhm.
for even medullary thyroid carcinoma in these people. Certainly none with other forms of thyroid cancer. And in general, it was determined that insulin carries more of a risk for thyroid cancer than GLPs. And guess what? Insulin doesn't carry a risk for thyroid cancer. Like it's not
Right.
a thing. So it's just not a significant true concern for humans. I do think in people with a history of medullary thyroid carcinoma, a family history of someone close to them, or another form of endocrine tumors called multiple endocrine neoplasia, I wouldn't put my patients with that history on them. But patients with papillary thyroid carcinoma, anaplastic carcinoma, like these are not contraindicated in
Mm.
these populations to use GLPs whatsoever. And it spreads like wildfire, these rumors. I have people tell me, well, I have a thyroid problem. I have hypothyroidism. I can't go on a GLP. No, that's not a thing. I have
Yeah.
Hashimoto's. I can't go on a GLP. That's not a thing at all. So, I think the research is clear Now it's about spreading the actual scientific facts that people deserve to know.
Yeah, and I think, at least, again, just assuming the best of intentions, I've had several people that I've talked to, even just friends and family members that were, well, I talked to my fill in the blank, and they said I can't because I have a
Mhm,
thyroid issue. And it was like, well,
mhm.
wait a minute, and this is a very, very specific cancer in rodents, and so because I read the same study and I did not see any of the other, didn't look into anything further, but I appreciate you pointing out the other data around that topic, and clarifying that as far as there's no other, and correct me if I'm wrong, but is there any other black box or you're on the naughty list, do not pass go, don't do this type rules relative to these other thyroid cancers when it comes to GLP-1s?
None, not at all. There is not even a warning, not even a
Mhm.
contraindication. Also, I should add a little color. I made our patients in Modern Thyroid Clinic that were in our weight loss program for years go get an ultrasound every 3 months because I'm neurotic,
Sure.
never had an issue.
Mm,
So, again, I had to solidify my own knowledge, especially before a lot of these other studies came out showing that they were completely, safe in terms of nodules and things. Nodules also are not a contraindication to these medications. Like, full stop, period. That is not a contraindication. If you want to be careful, go get you an ultrasound every quarter, every 6 months.
sure.
It's cheap, it's no radiation. Like, if you want to act in an abundance of caution, then it's an easy thing to do. And the other aspect of these meds, when everyone's talking about them causing cancer, is they actually have anti cancer benefits. Like, there's a
Right.
13% reduction in breast cancer, I think a 6% reduction in colorectal cancer. And there are so many in between. I can track the stats. I have them reasonably handy if you'd like me to. But there are anti cancer facets to these meds. And all we're talking about is this theoretical risk of medullary thyroid carcinoma that happens only in rodents.
But that won't trend, right? That won't get any clicks or
Right.
views then. So, we
Right.
can't talk about that stuff, right? We can't talk about
Right.
the good stuff. We just have to
It's so
jump on.
frustrating.
No, I appreciate you talking through that. And I had one more follow-up to that. How would it, and I don't know if there's any uh research out there to support this, but you'd be the one to ask. So if someone did have their thyroid removed, they had this contraindication in cancer 5-6 years ago, it's removed.
Mhm.
Would they still be at risk, or because those cells are no longer there, they're not really at risk? You know what I mean? Like, that's kind of
Right.
one of the things I was asked by a family member who had her thyroid removed, and I was like, it's just asking my opinion. Not,
Yeah.
like I said, I'm not a writing prescriptions or a
Yeah.
practicing physician, so I'm just generally just trying to give them talking points to talk to somebody who will listen and dive deeper into the decision to move forward or not. And
Right.
anyways, so I guess I'll leave my question there.
Yeah. No, absolutely. So, like, in people that had a thyroid removal from papillary thyroid carcinoma, no, like, they can take these medications. Now, I always think risk benefit analysis with everyone. You have to talk through this with people on an individual basis. If they have a history of medullary thyroid carcinoma and they had it removed, it would make me pause. Like, I would go really deep with these people. Did you have lymph nodes removed? Had it spread at all? Did it go anywhere? You know? Um, and we'd have to carefully assess that. But I haven't personally put anyone with a history of medullary thyroid carcinoma on these meds, but I've put a lot of people with other forms of thyroid cancer on them.
Gotcha. And I'm curious to the dosing too. Like, is there a dose
Mhm.
response of when the risk goes up? Is there a threshold where it shows a greater risk, or has it not even been shown in humans to show a risk? I guess, do we know any of that? I'm just curious.
No, I mean, I think always with these medications in
Right.
particular, I think the poison's in the dose. Like, I am
Yeah.
completely in disagreement with the standard dosing
Yes.
protocol and what's happening. And that
Yes.
is why we hear about bad things happening online with these people,
Right.
because everyone is grossly negligently over medicated and just constantly increasing their dose unnecessarily. But I definitely think it's dose dependent. Now, that's not shown up in the research mainly because there isn't real risk showing up in the research for humans. But I think you can extrapolate data with these rats that got such incredibly high doses,
High
20 to
doses.
100 times the human equivalent dose. And also, obviously, the GLP receptor issue on their thyroid. But if they didn't have that much, who knows if that would have even shown up in rats?
Yeah. No, it's a good point, and I could not agree more because there's so many people that they've had such poor metabolic health for so long. It's like,
Yeah.
listen, I get it. You don't wanna take it because of whatever reason. Um, just use it as a tool to jumpstart things for you, perhaps. I'm not saying I'm, like, pressuring this, but just
Right.
trying to open up one's mind to think of all these things as tools and not necessarily like, you're on the max dose because it's definitely concerning how many, and again, this is not the clinician. Maybe there's, I guess it's different discussion for different time, how much of responsibility is on the clinician himself to not just read it and follow it, but they get these manufacturing, I just refer to them as like a manufacturing dosing protocol. Like, you do this for this many weeks, this for this many, this for this many. I'm like, wait a minute. Like, what if this person's walking after meals, adding more natural GLP-1 improvements, improving their blood sugar, the foods they're taking in, starting a resistance training program, like all these things we know that also help. Um, they don't need that much, you know. I've seen a lot of utility in using different, um, natural ways to improve GLP-1s in a lower dose, coupled with lifestyle modifications. That's way, way more effective and saves thousands of dollars. So, if ever investors are listening to me talk, they're going to run for the hills, but but it's still a right thing to do to make sure people are, as long as they're willing to do that, because it sounds like that's a lot of how you approach it as well, to where, well, no, I just want to jam as much of a drug into me to help to force me to lose weight. Like, there's not
Right.
many people thinking that way. Maybe there's some, but not the way to do it. So,
Yeah.
is that something you notice is a less of a need for the higher dose with other lifestyle
Oh my
changes,
gosh.
nutrition, et cetera?
In general, I mean, so basically what we've done is we've taken diabetic dosing and we've
Right.
applied it to the masses of people who don't have diabetes.
Right.
And honestly, I'm not convinced that diabetic people need that much medication. Like,
Mhm.
when we hear about side effects on the internet, muscle loss, hair loss, pancreatitis, gallbladder issues,
Yeah.
vision loss. These things are directly related not to the GLP, they are related to rapid weight loss
Yes.
because people are so over medicated. They are not eating food. And that is a problem in so many ways. And for the first like year in our program, we did standard dosing. And you know what? I wrote like 8 to 10 Zofran prescriptions a day. And I'm like, this is crazy.
Yeah.
Now we have done for years now microdosing, tailored dosing, meaning
Right.
we adjust it for each individual person. And we do not increase these medications if people don't need it. I have written one Zofran prescription in the last 2 years.
Yeah.
Like, yeah. And now microdosing is catching on. Other people, like we were doing that before there was a word for what we
Right.
were doing.
Right.
And now it's like, finally, I think people are realizing, and I'm so grateful because the dose is everything. And people need to feel good enough to exercise and build muscle mass. They need to eat enough to do
Right.
that. And the only way you can do that is if you're not so overly appetite suppressed that you're not getting the macro and micronutrients that your body needs to thrive. And if you are, these meds are huge for longevity. They have so many other protective benefits for our long term health and lifespan, but they have to be used in a much better way.
Yeah, no, it's definitely like you just said it so well about, they feel like garbage, they're not eating, and oh, you must work out, and then you have to meet this minimum protein requirement every day to not lose all this muscle and not have the desired look or have the Ozempic face that everyone wants to avoid. But yet the dose is so high, like, good luck, not going
Right.
to happen, right?
Impossible.
So,
Yeah.
no, it's definitely interesting, and I've just seen, just from kind of playing around in the, a lot, some of my background is I used to own a supplement company, so even playing around with some different berberine based products or some more mild things that help with regulating blood sugar and insulin response, very mild, um, at the in between dosing, has helped keep dosing lower. And that's kind of anecdotal. I don't have any solid research to back that, but it was just interesting to hear, even if it was placebo, I don't know, but it seemed to be the food noises people were reporting back, saying like, yeah, usually Thursday, Friday, my next shot's not till Monday. If they
Mm,
weren't doing like split dosing, they're like, that's when it starts to
right.
pick up. I was like, well, try some of these other just natural kind of things or shifting your diet a little bit differently during that time period to see if can you make it till Monday and does it lower the food noise or the cravings? And a lot of people, seem to, again, it's anecdotal, but seem to benefit and not have
Yeah.
to jam up like, well, I gotta go to the next rung on the pole. And it's like, oh, geez,
Right.
like this is so much of this medication.
No, I completely agree. And I think the lowest possible
Dose,
dose
yeah.
of these meds that people can be on, and it's effective. And by effective, I don't mean losing 4 pounds a week because that's
Right,
actually not healthy. That's not what we're
right,
going for.
right.
That is what we want.
Yeah, and it's very similar, and I don't want to get too far off on men's health,
Yeah.
but I deal with a lot with a higher percentage. We were talking before we started recording. We work with women, but with men, it's always like, yeah, yeah, I would like to get 200 milligrams a week of testosterone. It's like this isn't Amazon. Like, wait a
Right.
minute. It's like, well, that's what works, bro. It's like, well, wait a minute. And
Right.
I can say that because I'm a bonehead guy too. So we
Right.
sometimes don't have our brains fully turned on. And it's like, well, let's find your minimum effective dose. Let's find all these other things and micronutrients and things in your blood work that are binding this stuff up to where wouldn't you want to take less of this? Just a thought, and then actually get more or make that higher dose you're taking this that much stronger. That's not the case with these GLP-1s, obviously, but there are some other therapies where there's a little bit more of a room for safety to go a little bit higher, still be very safe, but you're still only getting a fraction of it because everything else is just trashed.
Right.
So I'm getting off on a tangent, but I'll reel myself back in.
I love it. No, I love it.
Um, I wondered I, I think one last, I don't know, we'll see where we go with this, but I did have another question on if you have any um, experience with like GLP-1 receptors in the gut and gut health and how that relates
Mhm.
to the dosing and or the effectiveness of these therapies. Is there anything you could share on that topic?
I think I could probably share a little bit more about, people are so afraid of GLPs because of the gut issues. In fact, GLPs make your gut healthier. So can
Mhm.
they make you constipated? Yeah. Could they cause, paralysis, gastroparesis? Yeah, that's directly related to not listening to your body and massively being over medicated.
Right.
But in most instances, when they're appropriately used, even at higher doses that are tolerated, they improve the gut microbiome. They improve the lining of your intestine to prevent leaky gut. They improve your body's ability to access what's called short chain fatty acids,
Mhm.
which is, what your bacteria produce that we need from our beneficial bacteria, or at least that's one of the things we need from them. It's been studied and looked at in both Crohn's and ulcerative colitis and improved outcomes in both of those.
Mm.
I think it's the future of autoimmune treatment to a degree. I see it reverse autoimmune disease in my practice every day. And ulcerative colitis is an autoimmune disease of the intestine. So, I think there's a lot of room for them to benefit GI function and health overall. Um, I think the farther someone is down the rabbit hole of sorts of lack of health,
Right.
the nuance the approach has to be and the
Yeah.
longer it takes to get outcomes. Like the farther away from optimal you are, the slower the process is going to be.
Yeah, no, it's I think you're dead on with that because what the reason why that question popped in my head is I had a friend of a friend that was, morbidly obese, really nice guy, but just he came in when I talked to him was the highest possible, like the top dosing and wasn't losing any weight. And I'm like, wait a minute. And so, anyways, it's another story for another time. But there
Yeah.
was a bunch of other things going on that was like, yeah, like clearly this isn't working. And then, as you mentioned, the poisons in the dose, and that was causing issues. Um, so yeah, which is there. I had one more curiosity on GLP-1s, and I promise to get us back on thyroid.
Yeah. Hey, it's my
uh,
other passion thing, so I love
okay,
it.
so I'm not in trouble. All right, we're good. Um, impulse control. I've read a little bit on some testing studies, et cetera, for like impulse control, have it be alcoholism, gambling, kind of these addictive patterns in the brain, and saying it works on the similar or same part of the brain as it relates to food. Some of these GLP-1s. I'm curious to what have you seen in either the literature or anecdotally or heard about, and just if there's anything to worth kind of discussing there.
Yeah, absolutely. So your GLP receptor can influence your feelings of almost like satisfaction,
Mm,
right? And and like what people so often describe as food noise, like this little voice in your mind that's like, oh, I want this. Oh, I want this. Oh, I
yeah.
want more. Oh, I want more. And so what ends up happening is that is not simply a receptor for food noise. That's a receptor for this impulsive, satisfactory seeking behavior, right? Like,
Mhm.
well, I need this to make me feel this way. Well, when that is already triggered and satiated, naturally, you look for those things less. And that's what GLP receptors are doing. And they absolutely work in the form of alcohol reduction, smoking, addiction in general. That translates, in my opinion, over to in multifaceted, but it triggers less of a risk for suicidal ideation and self harm. Actually, there's a 10% risk reduction in those. There is an 18% risk reduction in bulimia, which is sort of a manifestation of that same thing. I
Mm,
see it so strangely rewire patterns of disordered eating in women that they've had for years that I never expected this to happen, but it's
mm,
undeniable. And, I think it's life changing. And what I hear from my patients all the time is, I really used to drink like 2 glasses of wine every night.
mhm.
And I've just done that for years. It's like my thing that I do to unwind after a long day. And now I'll have like 2 glasses of wine a month. And I'm not even trying to not drink. It's just natural. And it's so cool because I think that's such a unique thing to touch on because it impacts our health, our life, our relationships in so many different ways. It's forever ongoing in the amount of ways that it can impact.
Yeah, and you do see that a lot with and obviously that's not what the podcast today is about, but just related to some of these recovery programs and such, or people
Mhm.
trying to clean things up in their life, whatever the uh, crutch is, if you will, or the
Mhm.
trigger that they have as they get healthier, they tend to have a dramatic drop off in the amount of times or the strength of these impulses. And I would think it's reasonable to accredit, drop in inflammation, improvement of GLP-1 receptors,
Mhm.
just better neurotransmitters, more
Mhm.
of the positive feel good things going on in their brain chemistry from the gut, from the body, etc. Um, so I think there's some utility there, but again, like we like to do often in the US, we're like, well, I have this problem and then I'm going to jump to this drug. It's like, let's bridge a little bit of that. But yeah, there definitely seems to be some utility there. And I'm curious to see how that unpacks. Cause I know there was another application that was approved. I want to say it was for sleep apnea, I believe.
Yep.
That was
30%
approved for.
reduction.
Yeah. So I'm just curious to see if that's going to unfold in the future too, because I know of some folks that had a history, and were in different recovery programs and started that for other reasons, like GLP-1s, getting healthy,
Mhm.
etc. And they started to report like, I don't even like, I can't tell. Not this isn't a, hey, you don't need to go to your therapies anymore, people. Like just take the GLP-1. That's not
Right.
what I'm saying, but it was just kind of interesting. So
Well, when it removes so much of the just really grit and bear it kind of a situation and helps give these people leverage and a starting point, I think that can be really powerful, especially when they're in the deep, deep darkness of addiction.
sure. Yeah. Um, no, I thank you for going through the rabbit hole of GLP-1s with me. I appreciate that. Um, I did want to circle back to women's health and hyperthyroidism, Hashimoto's, things like that. How do these, specifically for women's health, how do say Hashimoto's or hypothyroidism, or if you have to delineate between the two, like how do these things affect like the menstrual cycle? Like
Mm.
how do they play out? Is there certain things maybe women would expect to experience at different times in the month if they might have one of these conditions or one of these issues?
Yeah, good question. So I think it manifests in a few different ways. I think from a non-fertility perspective, it can shift your menstrual cycle timing. Like it can make your cycles go longer. Maybe you have a period every 45 days or 2 months. it can also do the reverse. It can shorten your cycles by way of lowering progesterone. One of the first consequences or sequela that I see with thyroid issues in women is a drop in progesterone. And that leads to like anxiety,
Mm,
irritability, agitation, insomnia, worse than leading up to your period, like PMS, that's worse, right? Um, Breast tenderness, rage, depression leading up to your period, heavy periods, crampy periods, moody periods, dysregulated cycles. So big, big impact. And then in the fertility perspective, I think this is honestly, I think it's a travesty because these poor women are going through IVF and spending all of this money and all of this emotional energy. And a lot of the time, it's just simply a thyroid issue that has
mm.
been looked over and not addressed. And these women are paying for it literally and metaphorically.
Yeah, and what is something if someone's going through that or in the future, is there anything else they could look for in that situation, or is it maybe just advocating more for additional markers on testing when they're going to their fertility doctor? Like, what would you recommend with that?
Yeah. So they need to get a full thyroid panel, like, and that's TSH, free T4, free T3, reverse T3, and antibodies,
Mhm.
TPO and thyroglobulin antibodies every single time. Not only is hypothyroidism associated with infertility, inability to get pregnant, stay pregnant, Hashimoto's carries a significant risk for the same, plus complications during pregnancy. And this is information women deserve to know, but it goes deeper than that. They need to be very tightly controlled. They need to be in extremely narrow margins that honestly everyone deserves to be in. But even the scientific literature recognizes this for pregnant and pre pregnancy planning women, where they don't recognize it for regular people. And I have, like, I can share with you the link to our thyroid lab guide that tells people, hey, these are the labs that you need, and these are optimal ranges. You cannot accept ever, I will say this from my deathbed, a clinician telling you that your thyroid labs are quote normal, because
Yeah.
99% of the time they are not normal, they are not optimal. And also, ps, there is no standardized definition of what's normal. So what are they even looking at to tell you that? You have to understand and ask those questions. Thyroid, especially in fertility, is not something women can sit back passively and not actively drive the care that they need and deserve, because medicine is not equipped to help these women yet.
No, it makes a lot of sense. Is it on your link tree? Um,
It is, and you know what? It's
I have it right here.
gift.modernthyroidclinic.com. I love it. It's my
Yeah,
thyroid lab guide.
so for those who are on audio, we'll be sure to put links in the show notes, but for the video, we're just going to the link tree here, and then would that be this one here, the Thyroid Lab Guide?
Yes, you got
Okay.
it.
All right, cool. Awesome. Good stuff. Good stuff. Let me circle back to that. Yeah, as far as other lifestyle modifications, and I'd like to maybe unpack nutrition separately first. Maybe are there certain things you see when someone gets one of these panels and it's not as effective or efficient, if you will, the thyroid function is causing a lot of these issues? Are there similar things you're seeing missing in like micronutrients or certain food sources that they need more of or a better balance of? Like, what are some common tips or things you see that you're giving out? And again, I know I'm kind of asking a more broad question here. A lot of individualized care, but I do this a lot on the episodes or on the podcast. So hopefully everyone knows that we're talking broadly.
Yeah.
What comes to mind when I bring that up, like any
Yeah.
nutrition things?
So, a few things come to mind. You know, our nutrition, our micronutrients and things that impact our thyroid in a few different ways. Number one is like the production, the activation of our thyroid hormones is dependent on a lot of nutrients. Selenium's one, zinc's one, magnesium, iodine, obviously, but most people have plenty of that. So, you know, you want to facilitate that by eating a micronutrient dense diet. And then the other thing is, you know, basically Hashimoto's is able to be influenced. Like, we can reverse this. I kind of mentioned earlier that I used to have a giant goiter and I used to have Hashimoto's. I don't have that anymore.
Mm,
Haven't had it in over a decade. And so, you know, you can influence that in a large way by food. And we've tested thousands of women with Hashimoto's and looked at inflammatory food panels like you guys run. And, of course, everyone isn't unique and individual, but there are definitely patterns that Hashimoto's people present with. And, if I had to rate the most common inflammatory food groups that I see, number one is dairy. I know we all thought it was going to be gluten, but it's
Mhm.
not. Number two is gluten. And number three is
Mhm.
legumes. Four is grains. Five is eggs. And six is like nuts and seeds. But by the time you get to nuts and seeds, it's like 5% of people. So most people don't freak out. You don't need to get rid of all of those, but those are
Sure.
things that propagate a lot of inflammation, which can cause Hashimoto's or it can halt the activation of your thyroid hormones. So, our body needs nutrients to run. There are fuel, not just for thyroid, for so many things. And I think unless we're intentionally addressing that, I think a lot of us are missing key nutrients for so much.
No, it makes complete sense. How that would tie in. In the same sense, is there anything related to like exercise changes, rest, recovery, anything under those uh, categories, sleep, etc., that you see improvements in thyroid from some of those lifestyle changes?
Yeah, absolutely. So, I think a lot of my people, especially, and I'm sure I kind of think a lot of your people too, are like motivated people. They want to get
Mm.
better. They want to be healthy. They want to do all the things. And sadly, sometimes that can bite us in the butt because they will push, push, push. And so, most people with thyroid dysfunction, especially prolonged thyroid dysfunction, have adrenal issues. Their adrenals are tired from years of compensating for low thyroid function. And so when they go to exercise and they push it really hard at the gym, instead of getting stronger, they're actually creating more weakness in their physiology. And that usually looks like I go to the gym and I lift weights and I run and I do CrossFit and then I feel sick later that day, or I need a
Mm.
nap and I feel tired. And that slowly progresses to more days and they feel like they have the flu. And that's a dangerous situation. And so the biggest thing from an exercise standpoint to me is one, find a way to exercise where you build muscle mass without burning out your adrenals, and then find a way to exercise in a low sustained way, like walking
Mm.
without taxing your adrenals, at least early on in the process, right?
Mhm.
Because you'll get stronger. Once we fix your thyroid, address your hormones, your physiology will become more resilient, but you never want to push it. It's not pushing through that kind of after effects of overexercise that's going to make you better. It's going to make you worse. And so, yeah, I try and tell my people stay away from HIIT. Stay away from CrossFit, especially early on. Stay away from anything that makes you more tired later
Mm.
that day. And slow weight training, allowing your heart rate to come down in between sets, is an amazing way to get stronger, protect you from so much of the metabolic issues that result from a thyroid issue, and not burn out your adrenals.
Yeah. No, it's a makes a lot of sense, as far as if they're already kind of overloaded, then they're, best of intentions again, but sometimes, you know, using a drill when a hammer is needed isn't really the best approach, or whatever the case may be.
Yeah.
Having the right tools to pull is going to be key with health. Um, I did want to grab a couple more questions. I know we're coming up on time shortly here, but I wanted to ask a more question related to like common myths when it comes to thyroid health. Like, what are
Mhm.
maybe the top that make you cringe a little bit? Those top one, two, three. You can pick as many as you would like, but whatever stands out to you. What are some common myths you wish would just go away?
Yeah. Number one is TSH or TSH and T4 is enough to understand what's going on with your thyroid hormones. Research shows that your TSH reflects about 1% of the changes in your T3. So basically, it
Mm.
is meaningless. In addition to that, someone's TSH is completely invalidated once they're on levothyroxine. That medication skews your TSH. And in fact, the worse you are at using levothyroxine based medications like Synthroid, Tirosine, Unithroid, Levoxyl, the better your labs will look if your doctor's just checking your TSH, even if they're checking your TSH and T4. So that's number one. Number two is normal does not equal optimal, right?
Mhm.
Like you can be debilitated, literally on disability, and be in a normal range for what medicine says is okay. How do I know? I was that person and I serve these people every day. So you have to know what optimal ranges are. And again, like what Joe shared with my thyroid lab guide will give you our ranges that we openly share from Modern Thyroid Clinic of what we're looking for. And lastly, levothyroxine does not work for the vast majority of people, nor will it ever. It is a medication that I give an analogy of crude oil for. We don't put crude oil in our car to make it run.
Mm.
We need it to make gasoline to put in our car to make it run. Guess what? If we can't convert that crude oil to gasoline, we're not going anywhere in our car. And we
Right.
are giving everyone in America, 90% of thyroid patients, crude oil with the expectation that they can convert it to gasoline, but most of them never can. They cannot and they never will. And so what that looks like is you still have thyroid symptoms even though you're on medication and even though your labs quote look good. And lastly, let's see, what would my last one be? I would say, do not believe anyone ever. If I could leave people with one message today, do
Yeah.
not ever believe someone when they tell you that your thyroid is normal and is not the cause of your symptoms, because there are dozens of reasons why it is. And 100% of our patients at Modern Thyroid Clinic have been told that, usually by like 2, 5, 12 doctors.
Yeah.
And then they come and they get their lives back. And that is what you're looking for. You do not need to continue to have thyroid symptoms just because you have a thyroid problem.
Yeah. No, that's great. I think it's more, it it seems to be even more, what's the word I'm looking for? More inaccurate, I guess, in thyroid health than what I've seen. I've seen it a little bit in women's health, but mainly in men's health, because the range, just as a
Oh
comparison
my
of
gosh.
testosterone, is such a wide range.
Right.
And they're like, yeah, you're normal. And it's like, well, I mean, it's a pretty
I'm
big
at
range here.
201. Right.
Yeah.
How is
Yeah.
that normal for a 30-year-old man? That's
Right.
like what a 90-year-old man should have.
And I see some of that, obviously, that you have like optimal ranges in thyroid, but there seems there's some pretty big ranges there, and there, as you mentioned several times now, there's several layers to that.
Mhm.
um and yeah, we didn't get into some of the other details there, but for everybody um listening, we'll definitely have links to everything in the show notes so they can get some of this information. And we do post like a blog post on our site with links to not only your resources, the episode, but a lot of some of the key takeaways from the episode, so everyone can, if they're more the reading type as well. But I appreciate you joining us. A lot of great insights. And just like I said, I know it's all going to be show notes. We've touched on a little bit, but just if you wouldn't mind, just one more time, to give everybody a couple places that they can engage with you on social media, especially for the folks on audio listening in. Where
Yeah.
where can they find you?
Yeah. So I love to hang out on social media. It's actually like my fun way to pass time. I'm McCall McPherson on Instagram, PA, sorry, McCall McPherson PA on Instagram and McCall McPherson on TikTok. You can find Modern Thyroid Clinic on social too at Modern Thyroid, and I hang out there as well. So hopefully I will see you there.
Awesome. Well, thanks again so much for joining us today, and for everybody listening in. Thanks for tune into another episode of the First Optimal Podcast. Be sure to send us your questions, comments, all those things. We'll do our best to answer them, but we'll definitely, we'll either reference McCall's information, or drop her a note, or put you in touch with her directly. So that way you can get all these answers that you're seeking. Don't be shy. There, definitely can't encourage you enough. Comment section, email us, DM us, whatever the case may be, or just go straight to the source. It'll all be in the show notes. So thanks again so much for joining us, and we'll see you guys. Have a great one. Take care.